I'm Kitty Riley. I'm the designated professional for safeguarding adults and for my sins the Mental Capacity Act lead at the ICB in Sheffield. And this is my colleague Nikki.
Hi everyone, I'm Nikki Kelly. I'm the Deputy Designated Nurse for Safeguarding Children. The designated nurse is on holiday today.
And we've been thrown in the deep end. So you should have had Mel Ripley from IDAS talking to you about domestic abuse. So instead you've got me, Nikki, trying to do a good impression of Mel. So bear with us. If there are any questions, we'll take some at the end. I didn't put the questions slide on because I thought, now, because we've been thrown in the deep end, we'll let you direct your questions to Mel, but I think that'd be a bit cruel. So we'll talk you through what we think is relevant in terms of domestic abuse. So you'll have to excuse us if you know all this information already, but I think it's really timely and a good reminder of the Domestic Abuse Act legislation that came into effect in 2021, because this has got some significant changes in terms of our role and functions of working in healthcare and safeguarding. So we've got now a really robust definition of what domestic abuse is. And the reason why Nikki and I are here together is because from a domestic abuse legislation perspective, whilst we know a child is that up until the age of their 18th birthday, the domestic abuse legislation and the Mental Capacity Act legislation throws us a curveball and starts at the age of 16. So we've got children who are impacted by the domestic abuse legislation all through their age, and then our adults as well. And we'll talk about the nuances in a little bit. So what is domestic abuse? So domestic abuse is a pattern of behaviours, or it can be controlling, it can be coercive, it can be threatening behaviours, violence or abuse between those aged 16 and over who have been intimate partners or family members. And it's really important to remember that family members bit, because that's where we see some of the challenges in around people understanding what domestic abuse is and what it might not be. And that's regardless of gender or sexuality. The domestic abuse definition does include forced marriage or so-called honour-based violence, female genital mutilation, and victims from all ethnic groups and genders. It's important to say that the legislation isn't gender specific. So domestic abuse legislation does cover everybody, but what we do know is that it is very much a gender crime, and we do see more female victims of domestic abuse. However, that might be because we don't ask questions more routinely of men, and men might not want to disclose domestic abuse. So that might be what skews our information and our approach to domestic abuse, but it is something that we all need to be considering. Incidentally, the Care Act, from a safeguarding adults perspective, has a specific category of abuse of domestic abuse. So that means that the two pieces of legislation are interlinked. They don't operate in isolation, although they can do. And I'll talk again about that in just a little while. So what are the different types of domestic abuse? We know about physical abuse, I think, frequently. That's what we kind of look for, that's what we see. That's easily recognisable when somebody is a victim of domestic abuse and they've been physically assaulted. But there are other parts of physical abuse that we can identify, for example, withholding medication or care and the physical impact on that individual. There's also things like sexual abuse, rape, images, forcing or pressurising people to watch pornography. All of this can be considered domestic abuse when it's done by a family member or an intimate partner. There's also within the domestic abuse legislation now the financial and economical control, and that's really important because that's what some of the subtle indicators have led us to know about domestic abuse, that people try to exert the control in different ways. Find a way to control somebody by not allowing them access to finances, and that might be preventing them from escaping the abuse or from carrying out day-to-day activities. And there might be, lots of control around what people do with finances. I've known before of a victim of domestic abuse who was asked to produce the receipts for shopping by the perpetrator to make sure that the evidence what was coming out of the bank account was what they were spending, and giving them a fixed amount that they could spend. There's also the emotional side of domestic abuse, the manipulation, the threats, the shaming, the embarrassing people, stalking and harassment, and that too is domestic abuse, and coercive control. So we're going to talk about coercive control in a little while, but actually we're seeing lots more coercive control, and I think we're seeing more of it because people are getting more clued up about looking at the indicators. So it's not the physical stuff, it's the more subtle stuff that's happening to individuals. And then with the Domestic Abuse Act came the specific crime around non-fatal strangulation, and that's really significant for you all and how you approach patients who have been victims of non-fatal strangulation. Many of you might be familiar with Dr. Amy Lampard, who's our designated doctor for safeguarding adults. Amy's been working with colleagues at Sheffield Teaching Hospital to look at a pathway to put in place around non-fatal strangulation, and how a victim might present, and what response from a medical perspective that individual might require, because what we know from non-fatal strangulation is that there can be significant consequences of having pressure applied to the neck, not just the emotional side but structural and brain injury. We also know that there's an overemphasis on physical abuse, and that's why it's important just to point out the different aspects of domestic abuse. So when you're in practice, it's really important to be professionally curious and to consider in context what the person's telling you, and be thinking about whether that could be domestic abuse. In Sheffield, we've seen this quite a lot in relation to our domestic homicide reviews. And it's a term that people often aren't familiar with, but it's adult family violence. And again, it's the recognising adult family violence as domestic abuse. So it might be an adult child who is a perpetrator of domestic abuse, for example, to a mother or a father, somebody who's related, but it's actually the another adult within the family that's contributing to the violence. So again, it's that personal relationship between the victim and perpetrator, remembering it doesn't have to be intimate. It's not intimate, it can be family members. And we certainly have had, the DACT websites, that's Domestic Abuse Commissioner, have got all the DHRs that have taken place in Sheffield, where you can see some of the reports and learning briefs on there. But we have had quite a number of domestic homicides where adult family violence is what's occurred in those households. So we need to remember that also you can have child-to-parent abuse, and again that's difficult when you're navigating the legislation, but anybody who's 16 and over, the Domestic Abuse Act applies. So if it's a child perpetrating domestic abuse on an adult, an older adult, a parent, that would come under the domestic abuse legislation. If it's somebody under 16, it's likely to be some challenges and difficulties trying to navigate which piece of legislation would be the best to support the family. But again, that's bearing in mind that the children within those environments have got the Safeguarding Children's Act legislation to support them, and adults where they've got care and support needs have got the Care Act legislation from a safeguarding perspective.
Right, so like Kitty's just said, the Domestic Abuse Act did change, and the significant change for us for children was that actually children then have now become victims in their own rights, whereas before they were seen as the bystanders, and the within children's social care and all the child protection plans, children were seen on child protection plans under emotional abuse or neglect, where actually now they are deemed to be victims in their own rights. which then poses a question to you guys as GPs and in primary care, that if you are informed of domestic abuse, actually there is a child behind this adult, there is then an issue you need to address. There's been a number of reviews, but to put it swiftly, obviously clearly the CAMS one at the bottom there, they found that actually children that were suffering with domestic abuse or suffering in households with domestic abuse, the ongoing trauma was significant and really impacting on their treatment and their ability to kind of move forward. So domestic abuse for children is significant, okay? And the law's changed to put them as victims in their own right. We have put links and videos and you'll be able to watch them in your own time, so you can have a see of those. Okay.
It's me again, sorry. Okay, so understanding domestic abuse. So what we talked about earlier about the different categories of abuse, you might see little indicators. It might not be somebody coming and disclosing straight out, I've been a victim of domestic abuse. We know that tends to not happen. We know it takes sometimes people a long time to disclose, if at all. It might be a professional probing and, trying to build relationships with that person to gain the trust to be able to, have those difficult conversations. But sometimes when professionals are working with individuals, because of that drip effect, it kind of stops them from seeing that this potentially could be domestic abuse. It might be within your practice, you don't see people on a regular basis. You might see somebody, then another GP might see somebody, then they might be seen by the nurse, and they're all telling them little different parts of information that nobody's putting the bigger picture together. So I suppose that's just a question back to you. How do you make sure that you're recording of anybody that comes in, if somebody else was to pick that information up and there is this drip effect, how you potentially could identify that. But we know domestic abuse doesn't have to be the same behaviour. It's not repeated behaviour. Quite often it's a range of behaviours that somebody's experiencing. So again, we need to be mindful of the differences in the different categories of abuse. And we know with perpetrators, it's a combination of tactics and that domination to build that power dynamic and that control over an individual to make them scared, to make them fearful. And I was listening to something the other day, a podcast, and they was talking about when professionals become involved with victims who are victims of domestic abuse, just accept the fact that you've already made the situation worse by being aware of it. How do you manage working with that individual, knowing full well that now a professional knows about it, that things might change? And so again, that's not to put you off in terms of having those disclosures and having those conversations, but how do we respond to the individual, knowing full well we've already made the situation worse because we know we're going to have to do something to support them, and they've then got to go home and potentially face that perpetrator of abuse. It says here that a lot of victims state that violence isn't the worst part of the abuse they suffer. Oh, okay. There we go. So violence isn't the worst part of the abuse that they suffer, and quite often it's a psychological impact that they're having to respond to. What we know from victims is that when they say that there is violence, quite often for that, at that moment in time, once the violence has occurred, then that's stopped, then, that abuse is going to stop, and that they can perhaps go to bed and they can sleep okay that night, knowing full well that, there might be something again tomorrow. When it's other kind of emotional abuse, it's that constant fear of what's going to happen next. So not the physical bit, but what is going to happen next? What's going to happen to me? How do I protect my children? And those are all the challenges what people who are victims of domestic abuse are constantly facing. And again, there might not be any physical violence, there might be nothing, but there might be coercive control.
Perfect. So, you've heard us talk about coercive control. These are basically behaviours, okay? These are behaviours that manifest in a variety of different ways. So the actual coercion is a pattern, okay? It's how that person makes somebody else feel and then changes their behaviour. So, for example, I might not do something knowing full well the repercussions later. That's a form of coercion, okay? But it might well also be that actually, if I do something, I'm going to get punished, or there's going to be, they might be frightened of what the consequences are. On the flip side, there's then controlling. So we talked a little bit about the financial control, the time management control, where have you been, what have you been doing, but yeah, all of these behaviours, these coercive controlling behaviours are a way to gain power. So to gain power over their victim, to become a subordinate effectively. But yeah, it's a way to exploit and control and dominate that victim. Sorry. So I'm not going to read them all out to you, you can clearly read. So, but these are some of the behaviours that you may well see. And in your day-to-day activities, you're going to have to be quite clever on how you assess and how you pull some of these out. And it might just be a simple comment, oh, I can't get that medication up today. And then they don't kind of go through with whatever. It could be a variety of things, but you're going to have to be quite clever and use your professional judgment and your professional curiosity to ask some of these questions to get some of these answers. Okay, but very clearly, domestic abuse is isolating. Okay, the perpetrators are very clever, and it is hidden. Okay, and it doesn't matter what class or what gender you are. It can be there.
Just in relation to coercive control, I don't know if any of you have heard of Luke and Reinhardt, two wonderful human beings, but the reason why they're very prominent in the world of domestic abuse, in particular in relation to coercive control, is because their mum and sister were murdered by the dad. You might not know that incident straight off, but actually what happened was, and I would expect there would have been a DHR in relation to that, is that the mum and sister were murdered by the dad in Lincolnshire. I think it was Spalding, outside a leisure centre, shot, killed. It was all over the news. And what Luke and Ryan do now is the campaign around coercive control, because what they were saying is that as children growing up, they didn't know any different. They didn't know coercive control was happening. They never saw any physical violence whatsoever. But what they did know is that the dad controlled all the movements. So when one of them was a really small child, they'd been diagnosed with some allergy towards nuts. And the mum wanted to leave the relationship, and the dad said that if you leave, I'm going to give the child, and no. So that started that coercive control journey. Just let her know that if you do that, there's a good chance that I'm going to kill our child. Okay. It continued. So whilst it didn't physically do anything, it continued to put the threats and the fear into Luke and Ryan's mum, and to the point of. In the home, he controlled all the finances, so the mum weren't allowed to have any money. He controlled who came to the house and who didn't, so he isolated her from her friends. When her friends did come round, he sat in the room with them, so we could hear all the conversations. They couldn't go off and have the conversations themselves. He also took all the light bulbs out of all the rooms in the house and just kept the one in the room that he was in. So when it was winter months, he knew that they'd all have to come and sit in the same room he was in. So he would know that those conversations weren't taking place without him knowing about this. But in relation to Luke and Ryan at school, quite often in safeguarding we talk about, extreme behaviours, identify these behaviours, that are problematic. What they say is they weren't problematic. They knew that something wasn't right, what was happening. So rather than being problematic at school, they were straight A students. They complied, they did absolutely everything they needed to do because they knew that by getting a good job and a good career, they'd be able to get the mum and the sister out of that environment. They took on this protective element, but actually it was really interesting to me to hear them talk about throwing a curveball in really to how we normally think about children who have experienced domestic abuse. Sadly, when they got to the point where they'd got a good career, they were able to get the money together to move mum and sister out, they moved abroad to be able to work. They managed to get a flat to move the mum and sister in. They came over, moved mum and sister in, settled them for a week, went back to wherever they were living at that time. And it's at that point, and only that point, that domestic violence came into it, and that's when he shot them. And Luke and Ryan talked really candidly about it and said that the only time they realised about coercive control is when they were sat in the police station and they saw a poster that described what coercive control were. They felt it, all these things they were experiencing, but they didn't know that it was a thing until they saw it in the police station. And the one takeaway from the session that they delivered that's really stuck with me, that I think would be really useful for you all to hear, is that when they were asked what professionals could do in order to support people who were victims of coercive control, were to ask them, what can't you do? We always say what's happened to you, but they said they would like to have been asked, what can't you do? Because then they could have told you about all the things that they perhaps aspired to do or wanted to do, just the day-to-day things that they were prevented from happening and couldn't do because of their dad. And that's a really sad story, but actually, you know, there's a lot of learning from that in relation to coercive control. So, we ask ourselves, is it coercive control or is it caring? And this is when we have to start and build the context around our relationships with individuals. So, you know, if somebody was to put a tracker on your phone to check where you're going to make sure you're safe, they can badge that as we're trying to make sure you're safe. But when does that move from just want to make sure you're safe to monitoring, coercive control, checking where you are? You know, you might have all seen it on Facebook if you're on social media, but people who have joint Facebook accounts where they can't have an account in their own right. To all intents and purposes, people can do that, but actually, is there something more to that? Is there somebody within that dynamic that wants to know what the other person's doing and how they're interacting with others? Picking people up from work, is that, you know, caring, supportive, making sure that you get to work? Or is it somebody making sure that you don't talk to anybody when you've left work, that comes straight home? Looking after finances so you don't have to worry about it. Somebody taking ultimate control, you know, and I'm better at managing money than they are. That's fine. But at what point does it become abusive and a concern? And these are all the kind of things that we have to start thinking about in terms of domestic abuse in particular. And we often hear, why doesn't somebody leave a domestic abuse relationship? Well, there's lots of reasons why. Danger, fear, isolation, shame, embarrassment, admitting that they've been a victim of domestic abuse. Sometimes there's very practical reasons that, you know, if they're going to be housed in a refuge, well, they're not always nice environments, are they, refuges? I don't know if anybody's ever been to one, but sometimes those who are victims of domestic abuse feel that living in the refuge is as bad, if not worse, than living with the perpetrator, because at least they know what to expect. So there's lots of different things that we need to consider when we're taking an approach to support somebody who's a victim of domestic abuse. And these are just some of the figures around why people don't leave. Fear of retaliation from the perpetrator. I mean, that's kind of goes without saying when the old rationale behind domestic abuse is fear, control, power dynamic, lack of awareness of what domestic abuse is. So, like I've just described about Luke and Ryan Hart, they didn't know what coercive control was. And I throw the question out to you just for consideration. You know, if somebody came and there was a victim of coercive control, would you recognise it as coercive control? and domestic abuse, or not? Or is it just, they're having a difficult time within the family at the moment? Fear of involvement of statutory agencies. Again, I don't think media helps, where when children's services get involved on Coronation Street, the children are removed straight away. We know that's not the case. But do our patients know that's not the case? It's up to us to impart that knowledge and to just drip feed that information on a regular basis to make sure that they know there are support services out there and they're not punitive, they're there to support. Lack of information about existing services that are available, controlling, abusive and isolation, emotional manipulation, all the things that are keeping people in their circumstances are all the things that they're experiencing anyway. So when you consider it and how people respond and the capacity in order to make these kind of decisions, you have to ask yourself, if somebody's in constant fear of what's going to happen, are they able to make rational decisions? And the answer is probably no. So we need to be thinking about that and factoring it into our support. For you?
Possibly. So what are you going to see? What are you guys going to see? So I'm going to put it out to you to have a think about what you might see. So gone are the days where we've got a GP that sees the same patient day after day, week after week. So sometimes you might not know some of these patients, but actually when you're reading through some of your records, are you noticing that there's a difference? Okay, this patient in front of me isn't appearing like what the last consultation said. Are they very watchful, almost the rabbit in the headlights, so they're wary of what's going on? Have they come in together and actually you're trying to get one away from the other to try and ask some of these questions and you just physically can't do it? Have you got injuries that you're asking questions and I walked into a cupboard? You need to be really asking, probing those other questions, probing that professional curiosity. Does it make sense? Are they asking or are they seeking permission before they go to go and do something or receive something or go somewhere else, when actually you would think you should have that choice of your own? Are they hiding something? Are they overdressed? Are they kind of, is it their presentation a bit bizarre from what you would expect? Okay, so you need to be monitoring some of these behaviours. You need to be looking and probably documenting it and kind of asking those questions about why, because it might be completely normal, however it might not.
We've also seen a lot in domestic homicide reviews nationally, but locally, what we used to call the toxic trio: substance misuse, so that's alcohol or drugs, mental health and domestic abuse. So I'd just urge you to consider that when you're seeing an individual who may have substance misuse problems and mental health, be considering if there's any domestic abuse going on, and whether you need to start probing these things. And there's other things more clinical that might be relevant to you, like frequent UTIs from a sexual abuse perspective, or termination of pregnancies, or losing weight because they're not able to, buy the food that they need to keep malnourished in a way that we would expect people to be able to. So there's other more subtle signs, but again, we've seen these a lot in domestic homicide reviews where some of these things have been indicators, and they are very subtle. And you can be forgiven for not identifying some of these and being able to put the picture together because of how our clinical systems work and everybody seems to be disjointed across the health economy. And having said that, we keep thrashing this word out, professional curiosity, but it does really make a difference when we start thinking about the why. So somebody's telling us something, well, why is it like that? What is the impact on them? What is it going to be like when they go back into their own environment? Who else is in that property? So Sheffield specifically, just flipping back to coercive control, we've seen the first male and first female convictions of coercive control, which is significant really, just to say that the legislation appears to be working, although I'm going to reserve judgment on the judicial service in relation to domestic abuse, because I think it could be a whole lot better. But these two individuals have been identified and convicted of coercive control. Now the challenge we've got is proving it, because we know that these are very subtle things that are happening to individuals. So again, it goes back to record keeping and being able to document some of these things in the way that people are saying them to you. So there's the evidence base, should this happen to a patient of yours.
Lovely. So what is going to be the impact? Okay, so if you've got families that are suffering with domestic abuse, what is going to be the impact on that unborn? Okay, so when you're looking at a lady that's presented in a pregnancy, those kind of, all that emotion, all that stress, possibly those injuries, and actually a lot of studies show that actually domestic abuse is more prevalent in pregnancy. So how many of you are asking some of those questions? Those routine inquiries about what's happening with your relationship? Are you seeing some of these mums on their own? Okay, it does have obviously lifelong impacts, domestic abuse. So what are the impacts on that child? Now, Kitty talked about the child that was an A star. Do you know what I mean? They're achieving because they have to achieve because it's easier. But what about the child that's playing up, that's the behaviour issues, that actually isn't able to regulate themselves, that has got real anger issues, but actually is it a learned behaviour or is there something else going on? Okay, what about those adolescents? How many of those adolescents are we seeing now that are actually struggling with anxiety, struggling with making relationships, they're socially isolated themselves? Actually, what does outside look like? What does inside look like? So you have got to see the bigger picture, and like we talked about the study with CAMS, actually, can these children go on to receive that support and treatment if they're already or still ongoing with the trauma of domestic abuse? Okay, it then does have that bigger impact. So prior to the domestic abuse changes in the domestic abuse bill, we used to focus massively on mum needs to change her parenting, or mum needs to, and I talk predominantly about mum being the victim here, it could be either way. But the victim has to change their behaviours, the victim has to become more protective of the children, and that's what the child protection. We weren't looking at actually the perpetrator, what needs to happen, what needs to change. So actually, has a parent got the ability to parent if they're living in fear? If they're constantly worried about where they can receive their next money to go and get the children a new pair of shoes when the kids have just picked a hole in their shoes, or where the next lot of dinner money is coming from, or the school trip that's just appeared in the school bag. Can they actually parent? Can they function? Okay, so is somebody going to be able to come into you and say, I'm really struggling with my anxiety, and tell you the truth about why they are so anxious? Actually, that's possibly a little bit about you pulling some of those threads and seeing what comes, seeing what happens, asking those very difficult questions from that all impossible box of craziness that's going to come out of it. But also, can they keep themselves safe? Have they got a plan? Because the most riskiest part of domestic abuse is the point where actually that victim's going to leave, because the perpetrator's got nowhere else to go. So actually the perpetrator, that will be the most risk that victim will have. So can you help? Can you look at it? Can you think about it? Can you have that very holistic view on what those impacts are?
Just in relation to maternity, I think we also need to remember we do focus quite a lot on the unborn child in terms of safeguarding concerns being raised about the woman. So if there's any safeguarding adult concerns there, we need to be making sure that we're raising those concerns, and again we'll talk you through that in a couple of slides' time. But the longer term of domestic abuse, we know there's a massive impact to life on domestic abuse. You know, there's nothing from an economic perspective that will ever outweigh the cost of life in terms of domestic abuse. But we also know the cost of the economy and the cost of the health service in identifying, supporting and responding to victims of domestic abuse is significant. It's significant. There's lots of research out there that tells us about that. And what are the impacts for individuals? Well, potentially depression, withdrawal, low self-esteem, emotional distress, poverty, physical disability, gynecological problems, post-traumatic stress, cognitive impairment, and that's the non-fatal strangulation potentially that we talked about, and isolation. All these things, when we're responding to them in terms of our roles and functions from a health perspective, are impactful for the individual but also on the health service. So again, one of the things that we like to just suggest is to consider, you know, that benefit of spending a little bit extra time with somebody we think might be a victim of domestic abuse, because actually the long-term impact could be reduced in all these matters if we can extend that time that we might spend with somebody up front. I know that's really challenging. I know you're all busy, and we're all grateful for the work that you do, but these are just some of the things that are worth considering. So in terms of the whole system approach, we know domestic abuse isn't just relevant to our patients. We know it's a system-wide problem, and in terms of how we approach that is challenging. The Domestic Abuse Act brought in a statutory function around having a board to oversee domestic abuse and all those nuances that come with that legislation. So we've got that. So that's when we get our domestic homicides. That's how we find out that we need to do them, because it's a role and function of that board. But there are also some very practical things in terms of the DASH risk assessment. This has been around for a significant amount of time now. It was put together by Save Lives, but it's a series of questions, I think there's 15, that you can use as a tool to identify the level of risk of homicide that somebody is facing from domestic abuse. There are challenges with that, because again, we know how busy people are, but some of those questions do alert us to some of the high level risks associated with death from domestic abuse. One of the questions in particular is, have you been strangled lately? Okay, so you don't need to go through all the questions if somebody has disclosed that to you, or you've identified that through your consultation. That automatically would mean that somebody's at high risk of death from domestic abuse. So if you've not already familiarised yourself with that, I would suggest that you do that, because that will really help in terms of framing your questions and understanding where the risks lie. What that will then lead us on to is people who we identify as high risk of abuse or death from homicide. It's a multi-agency risk assessment conference, MARAC. That's where a group of professionals come together to discuss the highest cases. It doesn't have to be consensual. If somebody is at high risk of murder, we've got a right within the public interest to be able to refer somebody into that service. And there are measures that can be taken by those agencies sat around the table to help protect or reduce the risk for that individual. Again, it's better if somebody does consent and want to have those conversations and those discussions, but it's not necessary for MARAC. There are support services available. IDAS, you would have learned all about IDAS if Mel had been here today, but IDAS is our domestic abuse service that offer training, and they're I'm going to talk to you about domestic abuse routine inquiries, but they're always supporting us with domestic abuse routine inquiries. We've also got the different models across the system, such as Safe and Together model, and that's taking a trauma-informed approach, not putting the emphasis on the victim to be the one to adjust the behaviour, but on the person perpetrating the abuse and holding them to account. Again, we've got our domestic homicide reviews. They're a process that are a statutory process that we need to undertake when a specific set of criteria has been met, and the purpose of those is to learn. It's not to apportion blame, it's to learn what went wrong and what we can do better to prevent anybody being murdered in relation to domestic abuse. The legislation did add into the statutory criteria for reviews when somebody's died by suicide, where we've got an indicator that the death has resulted from prolonged domestic abuse. And then we've got domestic abuse routine inquiries, which I'm going to talk to you about, and Nikki's talked you through trauma-informed approaches. Lovely.
Okay, so having a trauma-informed approach. So we talk about this across the city and we're wanting to be a trauma-informed city. So what does that actually mean? So this is where you're looking at the situation that's in front of you and you're actually understanding what's going on, and we're not just throwing ourselves in there with our feet first. Because does this victim that comes into your surgery really want you to pick up the phone and ring the police and you've got 2 police officers pitched up at their doorstep? They don't. It's not what we need, is it? It's not going to make anything any better. In fact, it's probably going to make it worse. So actually, being trauma-informed, having that understanding, creating that ability for that victim to be open with you and say, this is what it is, but I don't want you to do anything about it. Okay? And that's okay. Okay? So long as it's not children. But if the adult's coming in and saying, I am suffering with domestic abuse, my partner is very controlling, and I can't go to the shops without his say-so, okay? Well, actually, you can then work with that victim and say, well, what can we do to help you? How can we support you? How can we work with you to make this better? Okay? And that's when all your other services are coming in, because clearly, primary care, you're not going to have that ability to kind of deal with all that. You're going to then say, right, we need to look at this and we need to inform this person, or we need to get you in this service. Now, if it was significant, like Kitty was just saying, actually, we can ring the police and we can speak to the police and say, and I've actually heard it this week from a police officer saying, we requested a trauma-informed approach, which means that actually the police are going to think about it. They're not just going to wade in. So actually, we are becoming much more of a trauma-informed city. We are empowering these victims and the perpetrators to make changes. So have a think about how that being trauma-informed affects you, and actually get yourself involved in some of the activities and the kind of training that's going on through the city about being trauma-informed, because it's not just about domestic abuse, it's about everything. It's not about what's happened to you, it's kind of finding out that whole story. Okay?
And I think I'll caveat that with, it's one thing having a trauma-informed approach. That's how we approach people and make sure that we don't re-traumatise them. But if we need to take action, we need to take action, but we need to work with the individual to take that action, because quite often when victims of domestic abuse are talking, we need to ask ourselves, is it the victim that's talking, or are they talking through the voice of the perpetrator? Because actually they know by whatever they're saying they're going to reap the consequences. So it's just, there's lots of things to think about, but this is one of the ways in which we can try to minimise, reduce any impact or re-trauma. So I'm going to skip through this because you'll get this PowerPoint and just talk to you about the safeguarding part. So we've talked about children, and if the child's in an home environment where there's domestic abuse, you need to be, raising a safeguarding concern in relation to that child, because they are in their own right, a victim of domestic abuse. They're not just experiencing that. It doesn't matter if the child wasn't there, or they've not seen or heard it. They live in an environment where this abuse is happening. From an adult's perspective, if the adult's criteria from a safeguarding perspective in the Care Act is identified, you need to be raising an adult safeguarding concern. So that's somebody who's over 18 with care and support needs, is at risk of or experiencing abuse and neglect, and we know domestic abuse is in that category, and are unable to protect themselves. If that's the case, you need to be raising a safeguarding adult concern as well. You also need to be thinking about who else is in that family environment, because there might be other relatives in there that meet that criteria that we need to respond to. So if you've got an adult who's disclosing domestic abuse, and there's a child in the house, and there's an elderly relative in the house, you need to think about what other action you need to take, despite whether that adult's telling you that they don't want any interaction, because there might be other people that we need to protect.
Can I just 2 seconds? I know it's been a bit of a bone of contention across primary care with regards to this, because when you've got an adult presenting saying that there's a domestic abuse incident happened or they're suffering with domestic abuse and there's a child involved, you're then having to explain to this patient that no matter what they say, that you're going to have to make that referral to children's social care. So that's quite tricky for you guys, and we completely understand that. We are covered by the law, okay, so we can override that consent, but I think what's really important is how you approach that with that patient and say, do you know what, we're not just going to wade in, we will support you. These services aren't going to come in and take your children away. We're going to work with you to make sure that you've got the safest environment for your children and you to grow and achieve. So I think it is difficult, and we are here to support you with regards to that scenario, but I think ultimately we have to actually, the Children's Act says the child is paramount. That's the first point in the Children's Act. So ultimately that child will come first over the adult's request of no further action. Okay?
This is a slide just to say that it's not all about victims. We stop victims becoming victims by dealing with perpetrators. So if you get somebody who comes and discloses, God forbid that they do disclose that they're a perpetrator of domestic abuse, or from what they're saying, you identify that potentially there could be, there is support that we can refer individuals to who are perpetrators of domestic abuse to be able to get that support that they need. From a professional's perspective, there are other mechanisms that need to take place if it's somebody you work with who might be a perpetrator of domestic abuse, and that's the people in positions of trust aspect of the Care Act. That means if you are in a position of trust and you are a perpetrator of domestic abuse, then you need to engage your HR policies in relation to that, and it may be that this is come about as a result of a safeguarding concern. And then there's LADO, so that's a local authority designated officer in relation to people in positions of trust who work with children. What do we do to help you in relation to domestic abuse? Well, we've developed a programme to be able to try and offer some way of supporting you guys in responding to domestic abuse, because we know it's vast. We know it's significant, we know that there's a lot to take in. Our colleagues from IDAS have helped us develop the routine inquiry. You might have heard about it, you might not have done, but this is about asking routinely any unaccompanied patients who are 16 plus whether they're experiencing domestic abuse. And you can do that in a variety of different ways rather than asking them directly of the victims. It's seen as obviously the better approach than ad hoc inquiries, because it sends a message out that whenever that individual sees a professional, they're going to be asked regardless of their circumstances, and quite often we know from victims they prefer to be asked than to have to disclose. So that gives them the opportunity to seek out, if they know that every time they come somebody's going to ask them at one point, they might then disclose that they're a victim. We also know you're really busy, primary care, and getting busier and busier every day it seems. So what this routine inquiry does is it allows for IDAS to come in and support your GP leads, safeguarding leads, and to identify champions within the practice. So if you are asking those routine inquiry questions and somebody does disclose, other support within the practice is available to then wrap around that individual, either go through the DASH risk assessment, get them some signposting, etc, etc. It shares the load, takes the emphasis off always being the GP that has to do that, and obviously the consequence and impact on the rest of the patients by being able to offer that individual the support they need. So what IDAS will do is they'll come in and they'll offer some training to GP leads, to identify champions, to practice. They'll give you posters and materials to put up. They'll offer you an aftercare package to come and support you to discuss through any cases or challenges that you've got. And they're very amenable, so they can do this as and when it suits you. And I think that's a really good offer that's out there, and we would really appreciate if you are interested in that to make contact with either myself or Mel from IDAS, and we'll be able to talk you through what the expectations are. what we're finding from domestic homicide reviews is that when some practices are involved in those, one of the recommendations that they're saying is that they're going to get involved with this project. Really, it could do with people getting involved in this project before it gets to that point, just to offer you some support, as again, because we know how challenging it is. Sorry we've overrun. It has been a 2-hour presentation you've got in 40 minutes, so thank you very much. I don't know whether if you want questions now or whether you want to save it until the end.
Has anybody got any burning questions? Or would you rather have the next, is it the break next or another? Right, that's how I accept. Thank you.